Hey guys, John Adamson, the Rehab and Documentation Guru, out on a Sunday afternoon. Very casual, as you can see today, wearing a sweatshirt and a hat, and shuttling my wife and my daughter around for some shopping. And I thought I'd make a video about a subject matter that came up related to a morbidly obese patient. So I'm going to see if I can remember the statistics correctly on this patient. 4'11", 570 pounds. BMI, body mass index of 117. So, body mass index. A 40 or higher is morbidly obese. And if you think about it, if you've calculated the BMI on your patients, people that have a 40 BMI are usually pretty good size. So 117, that's just crazy, insane large. And it's really difficult to work with these patients. Once a patient starts getting obese, number one, it's not going to be safe for one therapist to work with them. You're going to need multiple people, especially if they're very debilitated. Number two, physically helping them because of their size, making it impossible to put any kind of equipment on them that will allow you to hold on to them, is next to impossible. And let's face it, those of us that have been around for a while have had the problem of trying to figure out, even if we could get let's say a bariatric gait belt around them, where does it go? And where it goes, which is usually up here, are we going to be able to even effectively hold on to them for safety and make it plausible for us to exert any type of force that's going to keep them from falling over? So anyway, a lot of people are commenting about this particular patient who I just mentioned, who was requiring 4 assist, very debilitated, had apparently been ambulating at some point, and now is in the hospital for an extended period of time, could not ambulate, could not hardly even move. And the question was, what's the role of the therapist? And I would say, aside from getting the patient to do some exercises in bed or after mechanically lifted into a chair there, or if there's some kind of mechanical device the patient could be fitted into to help them stand and have somebody monitor their vitals, not much. Not much. I'm really, as I've gotten older, I've become more and more aware of the ethics that you cannot put yourself in danger treating a patient. And this therapist was talking about how it was taking 4 assists to slide this patient over. And with a 570-pound weight and 4 people, I mean, that's a lot of weight. Even if you're sliding patients, that's a lot of weight to move. And I don't know about you, but as I've gotten older, I'm really into protecting myself because I have a while to go before I actually am able to retire. And probably a lot of you. I injured myself in my 20s doing a transfer on a patient that was pretty heavy. And it took me a while to recover from that. And I don't think my back has ever been quite the same since. I'll tell you what I did. I tweaked my mid-thoracic region. And I do believe, because, don't cringe, I went to a chiropractor, and they detected what I expected, was I had a slight rotation of one of my thoracic vertebrae, and very minimal, but I could tell, even just self-palpating, back when I had the shoulder range to be able to really reach back there. And that happened as a result of a transfer. And ever since, that area of my back's given me problems. And I really encourage you to not hurt yourself working with patients. Number two thing that I'd like to say about this situation is tell your patients honestly what you will be able to do for them and not. Now, I'm in a different scenario. I'm in home health, and I'm not mean. My comments, like on the Facebook group, or my comments here, might come across as being kind of straightforward and not exactly sensitive. to patients' feelings. But I tell my patients after we have a discussion about their rehab, if they're morbidly obese, and let's say they're not walking or they're having a hard time walking, I will tell them up front, we can work on your walking, we can work on your balance, but honestly, if you want to do something I don't think is safe, I can tell you honestly, I'm not going to catch you. If you go down, I'm not catching you. I had a patient who was 600 pounds, wanted to get back to transferring, and I was very leery working with her. And I had a male therapist assistant who was bigger than me who ended up going to work with her. But we were both about, he was close to my age, almost 50 at the time. And we both had to tell her, we're not going to be able to catch you. If you go down, we're going to have to let you go because we can't possibly injure ourselves. And, I'm like a quarter her weight. But she wanted to work on transfers. And she did get back, to the point where she was transferring some, but then she went back in the hospital. Because, let's face it, 600 pounds just ain't healthy. So tell your patients what you know you can do or not. Document clearly the expectations of the treatment, that the patient wants to proceed. Obviously, if you're in a facility, utilize all advantages you have to keeping the patient from falling. In a home setting, it's going to be a little bit different. They might not have that availability to have extra help. But there has to be some liability on the patient's part, because if they gut to being that big, that's on them. I hate to say that. Now, are there diseases that predispose you to gaining weight? Yes. Like if you have COPD and you're on a steroid, that'll predispose you towards gaining weight. If you have diabetes and you're on metformin or insulin, that will predispose you to getting fat. One of the conundrums of diabetic management is that the very treatments utilized to treat, I'm mainly thinking diabetes type 2, which is caused mainly by obesity, especially abdominal visceral fat, is you take a medicine that makes you fatter, which just, makes your diabetes worse. But the patient bears responsibility. A lot of people have said, oh, well, they might have fat genes, or, there is no such thing as a fat gene. There are certain people that predispose towards certain phenotypes or body morphology, but there is no fat gene. It is possible for anybody to get themselves fit. And I am a little bit of the pot calling the kettle black, as I sit here with a current BMI of 26, which is slightly overweight. So I'm working on it like middle-aged man from Saturday Night Live. But I'm very much aware that my choices are making it riskier for those around me to take care of me, if something were to happen to me. So one of the things I posited, I'm a little bit all over the place, I apologize, but one of the things I posited on this Facebook group post about this patient was, has anybody talked to the patient about doing a medically managed fast? And there are patients that have gone through even water fasting, very carefully monitored to drop their weight rapidly. And at that kind of BMI, you need to get that weight off quickly, because that lady is in danger for a heart attack. And we're really putting her at risk by trying to work on mobility, because the demand on this patient's heart is tremendous. If she's that debilitated that she can't even move herself in bed, can't even roll, getting her to roll is going to be requiring a tremendous amount of effort cardiovascularly. And at that weight, I'm sorry, your heart's not in good shape. It's in terrible shape. So pushing her physically without concurrent weight loss is just a lost effort. You might make some gains for a little bit, but that lady's going to end up being back worse than where she was. So one of the comments I made was that, and I tell patients this, weight loss is your number one physical therapy. You take away the weight, And a lot of them are arthritic too. I said, you take away the weight. Did you know that adipose tissue in your body causes inflammation? I said, you take away the weight, inflammatory processes will slow down, which means your joints, which are arthritic, will feel better. So I have a patient right now. She has a BMI of about 41. I calculated it. And I was very pleasant with her, and she's very sweet. I really like her. And we're talking, and she goes, I know I'm fat. She said it like that, and she brought it up a couple of times. And I said, if you lost weight, and I mentioned a couple of ways to go about it, you would feel tremendously better, and you might not need me. I'll do what I can given your current weight and your joint condition, but we're fighting a real uphill battle. Anyway, I told her about some things. I asked her if she would like me to get a referral for her for a nutritionist. And next visit I came in, she said, I've thought about what you said, and I like the way I eat. I said, okay, we'll do what we can. That's all I can do. But when you've got patients that are obese, you need to have an honest conversation with them about their weight. And a lot of them know that they're heavy, and they know that they should lose weight, but they need to be mindful of the fact that we're not going to get them back to doing functionality, ADLs, and mobility unless they make some concerted efforts to manage their weight, to do something about their weight, because they're just shooting themselves in the foot, and we're wasting our time and effort if they're unwilling to make those changes. There's something else I was going to say about that related to weight. I mean, just be honest with your patients. I've learned over time, 30 years in healthcare, that patients like honesty. You don't want to keep the cancer diagnosis from the cognitively intact patient just because it'll cause them to have great mental anguish. But if you've got somebody that's morbidly obese, they could have a death sentence just as soon as cancer. And you've got to tell them, look, this will lead to this. I have a patient right now. He has what's called metabolic syndrome, and his sugars have been normal, but periodic assessment of sugars, even fasting sugars, doesn't give you a good measure. And anyway, he's got a good amount of adipose, and he's non-weight bearing on both legs right now because of an accident. And I told him, I asked him about weight, and he said, yeah, I've gained some weight since I broke my legs, and he's going to be a while to recover. And I said, you got to work hard on weight management, because if you get other comorbidities on top of what's going on with you, it's going to be hard for you to come back. So be straightforward with your patients, because if you truly care about them, if you really care about your patients, you're going to be honest. And obesity has associated with it, obviously, diabetes, certain types of cancer, heart disease, lymphedema. How many people do you see with lymphedema who are skinny? Very, very seldom. It's usually obesity. One thing I look at, I know I'm going a little afield, but this might be helpful to you. When I'm in a grocery store, for example, like Walmart, and invariably you've got the heavy set people that even during the middle of winter, they're wearing shorts because they've got so much adipose tissue on them that they can't thermoregulate very well, so they're always hot. I saw a man, I thought it was a woman at first because of the amount of breast tissue he had, but it was a man, walked by me, very big, very obese. And I invariably always look down to their calves if they're exposed. And sure enough, he had hemosiderin depositing on his lower calves, which is iron deposits from venous insufficiency. And all I could think of was, I wonder if he's had cellulitis and when he's going to be in the hospital with at least cellulitis. So lymphedema. There are just so many comorbidities. And one of the problems with our healthcare system being so expensive is the failure of the patient to take responsibility for their own health care. Does it sound unloving to you? I know to some it sounds unloving, but it's accurate. It is absolutely accurate. If people did even a modicum of trying to take care of themselves and slimming down, the reduction in healthcare dollars expended would be tremendous. Of course, some of us might be without a job, although some of us are without a job right now. Anyway, I'm carrying on too long, but have the hard conversations with your patients. Let them know that dietarily they can be their best physical therapist if they're carrying extra weight. And I calculate BMI on every patient that I see that's clearly obese. I calculate BMI because BMI is a complexity, a comorbidity, and something to be addressed. Anyway, hope you're having a great day. I'll be sitting here for a little while my wife shops. Take care and God bless.